Good morning, good afternoon. Thank you. My name is Ertharin Cousin, and I am a distinguished fellow in the Center on Global Food and Agriculture at the Chicago Council on Global Affairs. And I want to thank you all for joining us today, especially to the members of the Chicago Council. And all of you are joining us for the first time today on YouTube for this On the Record program. If you'd like to submit a question to today's panel, please visit ccga.live. As a reminder, the Council is a nonprofit, independent, and nonpartisan platform. The views expressed by the individuals we host are their own and do not represent the institutional positions or views of the Council. So let's just get right into it. As nations grapple with the enormous global toll of this pandemic, COVID-19 vaccines have become powerful and much debated commodities. Wealthy nations, representing just 13% of the world's populations, have purchased, some would argue half, while others estimate as much as 86% of the global supply of vaccines. Country leaders put domestic interests first, resulting in what is now commonly referred to as vaccine nationalism. As a result, some projections suggest the vaccines will be widely available in wealthy countries this year, middle-income countries in 2022, and most low-income countries won't have full access to the vaccine until 2023 and beyond. But as the UN Secretary General recently reminded us, no country is safe until all countries are safe. And so COVAX, the world's largest and fastest and most ambitious vaccine drive, the unprecedented global initiative, was set up in last April to ensure that poor nations aren't left out, don't need to wait until 2023 for their vaccine access. This program is projected to cost about $11 billion and is funded by donor nations, and with an ambitious plan of accessing 100 million doses of the vaccine by today. Unfortunately, that hasn't been the case, despite the fact that foundations and corporations are aiming to provide more than 2 billion vaccine doses to low and middle income countries by the end of 2021. So COVAX is led by Gavi, the Vaccine Alliance, World Health Organization, the Coalition for Epidemic Preparedness Innovations, and with UNICEF as a key implementing partner, leading on procurement and supply. Today's panel will discuss how international cooperation and multinational engagement can ensure that we are all safe. And we are all safe in an expeditious manner, not in a slowly and disjointed manner that is now projected by some to be how this vaccine rollout will occur. So it's my great privilege to begin this conversation this morning with Dr. Seth Berkley. And he has served as the CEO of Gavi, the Vaccine Alliance, since 2011. And under his leadership, Gavi is a co-convener of COVAX and the international mechanism that we are hoping will help us overcome the challenges of vaccine nationalism. And so I want to get right into our conversation with Dr. Berkley this morning, with a talking and asking you, Dr. Berkley, with the wealthy nations, as I stated in my opening comments, having purchased most of the global supply of vaccine, and while we're seeing stricter export bans in India and the EU, COVAX response is responding to this challenge of vaccine nationalism. How are you addressing these challenges, and what other international cooperation instruments are needed to ensure an equitable vaccine distribution?
So, Ertharin, thank you for that question and for having me here today. Let me start with saying that we have experience in previous pandemics. In the swine flu pandemic in 2009, a few countries bought up all of the vaccines. And so when this pandemic began, we asked the question, what was the best way to try to move towards more equity in supply? Now, of course, we can't control what individual countries do, and a number of countries invested heavily in supply for their countries. But one of the challenges is to get people to understand that in a global pandemic, you really are only safe if unless everybody is safe. And the reason I say that is before the new variants, there was a sense that it was okay to just look at our countries. But I think now people realize that if you have large parts of the world that are under-vaccinated, you are going to see variants that are going to appear, and then those are going to be transmitted. So this is really true that we have to think not only from a humanitarian point of view, but also from a self-interest point of view that we supply everyone. So how are we doing? Well, we have rolled out vaccine now to 118 countries, now about 41 million doses, but we're not at the level we had hoped to be by now. And part of that is the supply constraints that you mentioned in your discussion. If you compare to what happened last time, we're 2.5 times faster in terms of doses, to 8 times the number of countries, and 20 times the volume during the same period during the last pandemic. But that's not good enough. Equity is about having equal access. And so what we would have wanted was to have doses available to all countries within a very short period of time. In this case, we were 43 days later for our first dose allocation, and then another 40 days waiting for WHO regulatory approval. But the plan, as you said, is to try to procure more than 2 billion doses this year, and then to get those out to all countries. COVAX has, instead of focusing just on low-income countries, because it was trying to hopefully reduce some of the vaccine nationalism, we asked if other countries would want to join. And today we have 191 countries engaged in the effort. But of course, the ones that are most further behind are those low and lower middle income countries who don't have the ability to purchase doses on their own. And therefore, it is critical that we make sure that they get supplied.
So if that criticality of ensuring that they get supplied would seem to require global cooperation. And so what mechanisms are in place to support that global cooperation, if any?
Well, of course, when we started, we had no money and we had no staff, but we, as quickly as possible, tried to raise finance so we could begin to put orders in for the COVAX facility in parallel with those orders that were being put in bilaterally. Now, one of the critical issues that have occurred at the beginning, nobody knew whether any of the vaccines were going to work, and certainly not all of them. So many of the wealthy countries diversified their portfolio, as did COVAX, and invested in lots of different vaccines just in case one or another didn't work or if none of them worked. And so as a result, what we now have is an oversupply of vaccine for countries where they have multiple different vaccines. And so what we are hoping is that countries will begin to release those doses, either by dose sharing, which means that they make those available to other countries, ideally through an equitable delivery mechanism like COVAX, or that they just make them available and let us purchase those so that we can get them temporarily close to the time that wealthy countries have had access. We also have invested heavily in developing country vaccine manufacturers. And one of the challenges in that has been that India, which was one of the early and large suppliers, by the way, we're the largest purchaser of vaccines in the world for routine vaccines, and India is the largest supplier by volume to that. So we invested heavily in getting them to supply vaccines, but as they've had a very severe second wave, they have reduced the allocations of vaccines that could be exported, and that has affected the availability of vaccines as well. So this is a very difficult challenge in terms of trying to resolve it.
There's so much to unpack in what you've just said. And let me start with the first question is, when you talk about dose sharing, when according to Gavi, COVAX will set aside 5% of the vaccine doses for buffer to be used in humanitarian settings or released in the case of severe outbreaks in a developing country. How will this process work, or is it working now? And if so, how will it work? And what humanitarians will be considered as a priority?
So first of all, the idea is to leave no one behind. And the first priority in that is getting countries to make sure that all of the high-risk populations in the countries have access to vaccines. Of course, the WHO suggestion is that includes first healthcare workers, and then the elderly, and then those with known comorbidities. But also, it's critical that they include populations that may be displaced or populations of refugees as part of their populations that are getting access to vaccines. Of course, there are situations where there are wars going on. There are parts of countries that aren't controlled. There are populations that are outside of normal systems, and there the humanitarian community normally will provide services. And we wanted to make sure in those cases that if those communities needed vaccines because they had high-risk groups in them, that they would have availability. So that's what the buffer is set up for. But of course, our first priority is to try to make sure we get every country doses and that we get doses to healthcare workers everywhere in the world. We had expected by now to have all healthcare workers vaccinated, given the delays you talked about. This is now going to take us perhaps another month or so, but that's really the first priority, is that health workers are protected around the world.
So in protecting health workers around the world, and you can't do that if you don't have enough vaccine. And you spoke to the challenge, the recent challenge that's been identified in India, where there's an export reduction. And some are even concerned about export bans of vaccines from net producing countries as opposed to those who are importing. The challenge that the response to that has been a call by some to lifting the IP on vaccines and giving developing countries and others the ability to manufacture vaccines in their own country. Do you see this as a viable solution?
Well, I mean, I think, first of all, when we're discussing the lifting of IP, that is related to all of the different tools, to drugs, to diagnostics. And the challenge is somewhat different for vaccines because patents are not the main factor that holds back vaccine production. It's know-how, it's having facilities, it's having the systems in place to do quality assurance, quality control, et cetera. So the most effective way to get more vaccine manufactured is to have technology transfers, which is two companies working together, sharing all of the know-how. Also, if there is IP, sharing the IP, but the most important part of that is the know-how. And that is how, for example, India has the AstraZeneca vaccine, because the AstraZeneca company shared the technology with the Serum Institute of India, all the know-how, so they could almost begin production and work on production immediately, not have to reinvent all of the processes that are necessary. So it's really that process. And the World Trade Organization, which is thinking about this, Dr. Ngozi Okonjo-Iweala, who is the new director of that, but formerly was involved in Gavi and COVAX, is looking for what she calls a third way, which is to encourage that every manufacturer that has capacity is able to use that capacity, and that companies are working to share those technologies and to work together to make sure that those manufacturers are up, manufacturing as soon as is physically possible.
So let me ask you one question before we go to our next speaker. We've been talking about the challenges of equitable vaccine distribution across the developing world in particular, but some have noted that there's been slow rollout even in European countries. What is the difference in how the US has access and distributed vaccine as opposed to what we're seeing across Europe?
Well, let's remember that the U.S. started off with a somewhat fragmented and not necessarily coordinated effort. Now there has been an intense effort to try to do that. But also, you have to think of the U.S. as one of the major hubs for vaccine production in the world. And in very early days, Operation Warp Speed invested $11 billion in at-risk manufacturing across a range of very experienced large facilities, which of course has meant that they've had large volumes of vaccines. That has meant they've been able to roll it out quickly. The challenge now is that at some point the U.S. will saturate its markets, and the hope is that U.S. will continue to produce vaccines at scale and make those available to the rest of the world. So far, there hasn't been any exports of U.S. vaccines, but that could happen. And where we're asking the U.S. to start is the U.S., like other countries, invested in lots of different vaccines. So, for example, there are doses of the AstraZeneca vaccine that have already been made and are sitting in vials. They will eventually expire. Those doses could be used in the developing world. They could be loaned to make up for the shortage in India. And then if the US needs them later, when those Indian supplies are available, we could replace those doses. So our hope is that over time, as countries cover their high-risk groups, that they will begin to make products available. One last thing before we go to the next speaker, which is critical, is there is now, normally the world produces somewhere around 3.5 billion doses of vaccine. When you add flu, it's maybe 5 billion. We're talking about going to 10 or 15, maybe even higher billion doses a year. There is now global supply shortages of equipment, of tools, and what's going to be critical is making sure that we don't see hoarding of those, because right now, for example, there are 42,000 liters of manufacturing capability that is sitting idle in a number of manufacturers because they can't get some supplies that are necessary to get those reactors or keep those reactors going. So, as we think about a pandemic, it's not just the product, it's also the raw materials that are absolutely critical so that we can optimize production for every manufacturer that has the capabilities around the world. Good morning, Henrietta.
Well, thank you so much for bringing in that last point, because we often talk about supply and supply shortages, but we don't look at the full supply chain that supports the manufacture of those supplies, and recognizing those challenges is critical to talking about the distribution issues. Let's bring our next speaker into this conversation, Henrietta Fore. Henrietta serves as the UNICEF 7th Executive Director. She has worked tirelessly as a champion to encourage increased economic development, education, health, humanitarian assistance, and disaster relief in both the public, private, and nonprofit sector. She's brought that energy, compassion, and commitment to her work at UNICEF, serving as a significant voice around the issues related to children and women in particular. And now she has become a leading voice on the need for increasing the access for the vaccine and supporting the Build Back Better movement in response to this pandemic. Welcome to the conversation, Henrietta. So good to have you here with us today. Let me ask you the first question. UNICEF is playing a leading role in the efforts to procure and supply doses of COVID-19 vaccines for many low and middle income countries. What are the unique strengths that can be leveraged by UNICEF in this procurement, as well as in the logistics and storage of vaccines? Because we know these vaccines, many of them require freezers and other storage facilities that are not widely available in many developing countries, and particularly in fragile state countries. And in particular, what is your greatest obstacle to meeting the vaccine needs of the citizens in these countries, particularly of women? Welcome.
Ertharin, thank you very much. It's a real pleasure to see you and Seth this morning, and John. So thank you very much. Well, as you mentioned, UNICEF has been working in vaccines for many years, and about half of the world's vaccines go through our doors because we are doing the routine immunizations like measles and polio for children all around the world. And we do this in partnership with Seth and Gavi and with WHO and with all of our partners. So we have a good foundation to build on. So 2 billion vaccines that we have been moving a year are now an additional 2 billion vaccines for COVID. So we're doubling, to Seth's point about the sheer volume of what's going on. So it's a massive undertaking. But for us, to your question, Ertharin, it's the readiness of the countries that's the biggest challenge for us. So we do procure the vaccines. We also procure protective equipment, so gowns, masks, the things that you will need in the community health clinics to try to help. We also are involved with treatments and buying diagnostic kits, but procurement is just one part of what you need. You need a whole supply chain, as you said. Mm-hmm. So we also are involved with logistics and freight forwarding, and this is a massive public-private partnership. We have about 300 companies and entities that are helping us move this around the world. As Seth has said, we've gotten 40 million vaccines out to a little over 100 countries. It is a logistics, it's very complex. And then once it's in country, we need it to clear out of the, and come off of the tarmac. So it has to be approved by a country. There has to be a way to move it with transportation, the cold chain that you talk about. With Seth and Gavi, we have been purchasing refrigerators to help us along these supply chains. So there are about 80,000 new refrigerators with solar panels to make sure that vaccines are going to be cold every step of the way. And then we have to be sure with the Ministry of Health that the healthcare workers are trained. They're the frontline workers, but they need to know exactly how much of each serum. There are several types of vaccines that are coming in, but they need to be trained. And then it's very important that we actually talk to the people, so that we talk to people about what a vaccine means, that vaccines work, that it can help keep themselves and their families and their neighbors safe. So all of this becomes a very important supply chain, and one in which countries all over the world are hard at work on. But if you're a very fragile country, which Ertharin, you know and have worked in, the healthcare systems are very weak. And so they are really scrambling to try to meet the challenge of the moment. It's a race against time.
when you talk about those fragile countries, we can't avoid talking about the conflict states. We know from my standpoint, from a food security standpoint, that's where such a large proportion of the acutely hungry are located. And much of the challenge is humanitarian access to those populations. With the description that you've just given of what is necessary to prepare and the healthcare population for supporting the needs of their citizens. In conflict states where access is also a challenge, how do you overcome those issues to ensure that the healthcare community has the tools that are necessary to meet the needs of the population?
Access is a very big issue, and it is important in conflict states, cross-line and cross-border. So we are deeply at work in many countries. So in Syria, for instance, running a campaign is difficult, but if you can work with all of your partners in country, we hope to get them done. Democratic Republic of Congo, South Sudan, Yemen, all of these countries are very difficult, but we are a partnership out there in the countries, and we work closely together. And together we advocate for the ability to have access. Humanitarian workers are not able to move as freely as they have been in years past. They are often targeted. Seth and I have some examples of our polio workers who have been shot while working. It is important that there is trust in a community, that they understand what vaccines are, and that they are there to help their children and their families, the people of their villages. And if we can get that message out with the national government and with all of the local elders, religious groups and others, leaders of the community, particularly women, Ertharin, they are trusted voices in a community. And if they will help, if they will speak up at this time, it is a very important asset for all of us.
So those assets and the challenges of reaching those hard to reach communities brings us to our next speaker, Dr. John Nkengasong. Dr. John serves as director of the Africa Center for Disease Control and Prevention, a specialized technical institution of the African Union. He was appointed in 2020 as one of WHO's special envoys on COVID-19 preparedness and response. We appreciate you joining us here this morning, Dr. John. COVAX aims to supply 600 million doses to Africa, enough to vaccinate at least 20% of the population. You have stated that if we vaccinate at least 60% of the African population in the next 2 years, then this pandemic will be over. But if we vaccinate slowly, it will take us more than 5 years to put the pandemic behind us. And we would be living with, and those in Africa would be living with the real pandemic and the prospects of moving toward an endemic situation on the continent with COVID-19. So what are some of the key challenges facing the continent in getting the vaccines done within the timeline of the next 2 years, as you've stated? And how do you overcome vaccine hesitancy, as we've seen in countries like Malawi, where we've been forced to destroy vaccines because of citizen vaccine hesitancy, issues that are now impacting populations across the continent?
No, thank you, first of all, for inviting me to be part of this conversation, and greetings to Seth and Henrietta for meeting you again on this platform. I think that the Zooms have become platforms for more frequent meetings than in this topic than any other time in our recent history. So we, as a continent of 1.2 billion people, 55 member states, and as a specialized clinical institution of the African Union, we went to the head of states and did a simple modeling. We said, look, if we need to look, the question they asked us was simple. I mean, the United States and Europe are trying to vaccinate up to 80% of their population and above. What is your situation? And we said, well, if we vaccinate 60% of our population, at least 60%, we will be good. Because our population, our continent has a lot of young people. I mean, about 40% of our population is under 15 years. So you take that population away, you left with about 780 million people. And we are very grateful, first of all, to COVAX. COVAX, I listened to Seth carefully, is a great, I've said this over and over, that is a true symbol of our global cooperation in the health security area for vaccines, and global solidarity, that we all agreed on the principles of global solidarity and global equity when the pandemic just started last year. We said, all of us collectively, all the right things, that we have to be to fight this collectively and express solidarity. The reality is that twofold. One, you ask, what are your greatest challenges? Your greatest challenge is access to vaccines. Okay, that is number one. I think if you put the vaccines in our doorstep, we will use the vaccines. The vaccines that COVAX distributed a few weeks ago in most countries, with rare exception that you touch on, have been used up. Okay, I mean, in Ghana, in Nigeria, in all the other countries, Rwanda, they have been picked up. So I think that is clearly a sign that even though there's vaccine hesitancy and a lot of misinformation, people realize that vaccines will save lives and vaccines will save economies. I think that is clear. The challenge you have now is just twofold, that a global solidarity and access has to be expressed in our collective ability to support COVAX, not with the money, but with access to vaccines. Because I mean, the most I'm looking for, I'm not an native English speaker, so I'm looking for my words here, is, I mean, a difficult situation to put COVAX is to give them a lot of money and then close the access for them to use the money to get vaccines. I think that would be, I mean, then on the surface, it looks like, look, we are supporting that with a lot of money, but they don't know where to go get the vaccines. I think all vaccines that come to Africa are vaccines. I mean, and they all help us to contribute to the 60% goals that we have stated there. So it is an appeal that that vaccine diplomacy, we understand it, but our definition of vaccine diplomacy is the ability for a partner, a friend of Africa, and others to support either COVAX so that they can get the doses, or you support the African Vaccine Acquisition Task Team, which was set up by the African Union to complement and augment the doses that COVAX was going to give us. Those are the only two mechanisms that would meet our definition of vaccine diplomacy, i.e. enable us to get to our target, period. I mean, we really want to be clear on that target. That just to summarize, if you want to support us, support COVAX. If you want to support us through AVAC. Those are the only two mechanisms that will make the continent look right.
So, Henrietta spoke to the challenges in fragile states and lower income countries, and the International Rescue Committee estimates that all the extra supplies bought by the US, the UK, and the EU could vaccinate everyone age 16 and over in the 20 countries most at risk of humanitarian disaster. Out of these countries, 13 are in Africa. Could you speak to how these conflicts could derail the continent's fight against the pandemics? And speak to the issues you talked about, to heads of states' commitment to distribution of vaccines. How are you working with heads of states in these fragile states and conflict areas, and particularly those challenged countries, those 13 challenged countries across the continent, to ensure that access is provided to support the necessary vaccination of that 60% of the population?
So that is a very good question. My fear is that when the history of this pandemic will be written, it will be captured that we knew what to do, and we had the tools in our hands to do the right thing, but we didn't do it. I think that will be a very sad page of the history when it's read by those who will read history of this pandemic. And I'm absolutely sure that we know it is in our power as humanity to be able to support either COVAX and AVAC to get the vaccines available. If the vaccines are available in a timely fashion, you can block the spread of this pandemic this virus from spreading from major cities in Africa to those those conflict regions. The greatest burden of of the disease is still in major cities. I mean, in the city of a capital city of Addis Ababa, 60 to 70% of the infections are still in the capital city. Okay, if the vaccines were released, available, then we can vaccinate at speed and at scale the major cities, then it will reduce the chances that the virus will spread into those conflict areas and seed itself into the conflict areas. So we know what to do. We just don't have the vaccines to do that. If I have vaccines today in in Ethiopia, my priority would not be to go to a conflict region and start vaccinating. My priority is to take the war where the enemy is. And the enemy is in Addis Ababa, is in Nairobi, is in Kinshasa. If you go to DRC, instead of going to North Kivu where there's conflict, then 80% or 70% of the burden is still in Kinshasa. So we have an opportunity to do the right thing. But those excess doses of vaccines that are in deep freezers in some capitals must be released so that COVAX can distribute the vaccines. People can get their second doses. COVAX distributed their first doses some weeks ago. Now countries are asking when would we get the next doses, and we don't know the answer. And this is not about COVAX. It is about our people, the people of Africa. I'm the director of Africa CDC, the public health official for the continent, and I have to address those questions every day. Seth is doing what he can do in Geneva to support us, but it is not his responsibility to that. It is our responsibility collectively as people living in the same planet and humanity to address this issue collectively.
Well, I appreciate that, doing the right thing now. But let's get to some tough questions. And Seth, let me come back to you. Over the past few weeks, some countries have discontinued the use of some vaccines because of negative side effects. How are there examples like these that would potentially affect the supply of vaccines that each of you as speakers have acknowledged is a critical issue to ensuring that we reach the levels of vaccinations that are required to address the pandemic?
So thank you for that question. And of course, let me say hello to John as well. And it's nice to see you because we are all working together at this problem, but it is a very thorny problem. And so I think, it takes the leadership of all of us to try to make this happen. To answer your question, the vaccine that has been most criticized is that of AstraZeneca. And we've watched at the beginning, for example, a number of countries say we don't want to use it in the elderly because there was no data. And it's true, in the original trial, there was no data on that vaccine. When they ultimately used it in populations in Scotland, they found not only did it work very well in the elderly, but even in the over 85. So data then did that. But then there were other concerns. And most recently, there have been concerns related to central venous sinus thrombosis, which is a quite rare side effect. Now, I think we need to put that into perspective, and we need, first of all, really good surveillance around the world for the problem. It's interesting because this problem has been seen in a number of wealthy countries. A lot of vaccine has been used in developing countries, particularly India, of this vaccine, and they haven't seen the same incidence of it. But I think we have to continue to look, because is that a difference in surveillance? Is that a difference in genetics? Is it a difference in the population that's getting it, et cetera? But just to point out where we are. So if you look at natural COVID infections, you have a 40 in a million chance of having central venous sinus thrombosis. If you look at some of the mRNA vaccines, it's probably something around 4 in a million, a recent study has shown. So we don't know yet what the numbers are, but the regulatory agencies who have looked at this have said these vaccines are safe, they are effective, and they work to protect against this infection, which is far worse. In other words, the benefit to risk ratio of that vaccine is still good. And so our view is to follow that advice and to continue to collect information and understand where they are. The last thing I'd say about this is that some of the countries that have suggested they wouldn't use the vaccine are countries that have other choices. So if you have 5 vaccines, it's easy to say, well, I'll use these 3 and I'll put a hold on these 2 until we get more information. But we're not in that situation worldwide, given the shortage that John and Henrietta and myself have talked about. So we will continue to try to get more vaccines from any producer, as long as they're safe and effective, and go ahead and have regulatory approval. But we also need to make sure that we continue the very careful safety monitoring to understand how these vaccines are what they're like in real world conditions.
So as you speak about the vaccine in real world conditions and how we use them, Henrietta, you spoke about the work you and your colleagues are performing to ensure access of the vaccine and all the other tools that are necessary to support the population. Oftentimes in these conversations, the appeal is made for financing and funding. As a voluntarily funded organization, are you receiving the financial resources that are necessary? Is there enough financial support coming? And if we overcome the financing problem, will that provide you with the resources that you need to address the challenges of the affected populations?
So, Ertharin, you are right that financing, funding, just money is important in this. The entire system for the world, for getting many of the vaccines out to John in Africa, are dependent on funding. So Seth and Gavi have been asking for an additional $2 billion, and we could use another $650 million for preparing the public health systems of many of the poorest countries in the world. They are just very fragile. And as John knows, in Africa, it is not just in Africa, but many of the countries are in Africa. And if we cannot help them with the public health needs, it means that it's very difficult to move the vaccines and to reach the immunity levels that we wish. So we are starting with the vaccinations of the 3%, the frontline workers that are needed, but then we need to get more vaccines out so that we can reach the 20%. Funding is needed for the poorest countries, the lowest income and the low middle income countries. The first 20% are free. They are covered by overseas development assistance from a number of donor countries. But for those countries that can afford to pay, who are in upper middle income or who are highly developed countries, they are paying themselves. And what Seth talked about is that the COVAX facility is meant to operate in parallel. So the COVAX facility is trying to get the equitable, fair, and affordable distribution out to particularly the poorest countries in the world. But there is a whole nother parallel track that are for the richest countries. And right now, his call for import and export bans being lifted, intellectual property rights being shared, and the donation of doses or the loaning of doses from countries that have enough, it would be very helpful. It really is a race against these variants. And so the faster we can move all of these facilities, the sooner we will get on top of the pandemic.
Well, thank you, Henrietta. And John, Henrietta spoke about those variances and the third waves that we are now seeing. And in many countries across the continent of Africa, we have not seen the first vaccines to support the essential workers being distributed. So what's necessary? Yes, we know we need cooperation, but let's talk about specifics of what does the continent need from the global community to support an uninterrupted supply of vaccines and the other tools that are necessary to provide the access to the populations that will get us to that 60%, but first to the 20% that's been described, and then ultimately to the 60% that you hope to achieve.
No, absolutely. You don't get to 60 without going through 20.
Yes.
I think that is a simple process. I mean, here on the continent, we use a very simple formula that vaccines plus vaccinations equals life saved and economy saved, which is very important. I would like to bring in the economic component because the impact, the harm that is causing on other diseases like the HIV, the TB, the malaria are huge. I mean, and you can only stop that by stopping or eliminating COVID from the continent. I think Seth touched on this earlier in his introductory remarks, and I repeated that when I said we know what to do, and we don't want history to judge us that we knew what to do and didn't do it. And we don't want the scenario of 2009 to repeat itself, where the richer countries got their H1N1 vaccines, and then after the pandemic was over, they donated those vaccines to the developing countries, including Africa. So the formula is simple. One, if you have vaccines out there, this is an appeal to all our friends and partners of Africa. If you have vaccines out there in excess, redistribute them now. I think that is the only way. Meet us at a point of need now, rather than give us the vaccines in December or January when the virus must have seeded itself across areas that we cannot flush it out. Okay, we need to do a massive, rapid scale-up campaign vaccination now. Ethiopia was able to vaccinate 13 million children with measles, against measles vaccines, using measles vaccines, I beg your pardon, in the middle of this pandemic. Again, Ethiopia was able to immunize 13 million children with the measles vaccines in the middle of this. This points to the fact that if the vaccines are available, they will be used. They will be rolled out on the continent of Africa, and will meet our target as stated in our continental strategy. So again, a solemn appeal to those having excess vaccines: redistribute them now, throw them into COVAX so that we can plan for it, and then use that in immunizing our people. Second and last is that this is a global threat. If I see the number of variants that are emerging, or what they call variants of concern, and you look at that on the continent and you compare that with other parts of the world, I think that, already it's a signal that if we do not do this, then when the whole campaign against getting rid of this pandemic will be very, very challenging. Even in areas of the world that vaccination has occurred, we've learned a lot about this virus, but there's still a lot we don't know about this virus. So the best way to deny the virus the ability to mutate is to vaccinate at speed and at scale.
Well, Dr. John, you've spoken very eloquently and passionately about the need for a distribution of additional vaccine and delivery of additional vaccine to the continent. Seth, earlier in our conversation today, talked about the potential for partnering for manufacturing in different countries of vaccine. What is the opportunity for those types of partners to bring development and manufacture of vaccines to the continent?
No, absolutely. I think we are looking at both tracks. When you have a problem, you kind of triangulate your thinking. I think thinking number one is what I just described. Thinking number two is how can we start galvanizing the continent for local manufacturing. Just last week, exactly 1 week ago, we had an extraordinary summit where everybody came together. Seth was there, our colleagues from CEPI were there, WHO, World Trade Organization, UNICEF, and in 2 days, there were 40,000 participants that assisted in one of the 11 sessions. That just shows that there's great need. There's a cry out there for regional manufacturing capacities to be strengthened in Africa. Africa produces only 1% of its vaccines and imports about 99% of its vaccines. We have to collectively, and I like to underline the word collectively, work on reversing that so that in about 20 years, the continent begins to manufacture at least half of its vaccines. And if we do that, we are doing that not just for Africa, but for the collective health security interests of the world. If we do that, we are helping to guarantee vaccine security so that we do not get into this dialogue when the next pandemic hits there. We should be developing, building a boat and riding it as we fight this pandemic, not wait until it is over, then we begin to think of what do we do going forward there. So a partnership has been launched at the highest level of the continent called Partnership for Vaccine Manufacturing in Africa, in abbreviation PAM, and we're welcoming all partnerships to help the continent. There are hubs in Africa that are already producing vaccines, not necessarily COVID vaccines, but where you can have constructive dialogue and engagement with them. And I think in the next couple of years or even months, I mean, some of the new technology that the mRNA can actually be transferred on the continent of Africa to support this program. Let me just end by saying that in the spirit of saying we don't know where we are going with this pandemic, is that we don't even know for those who have been immunized if they will require a booster. We don't know if the vaccination will be like annually or not. So again, if all the two scenarios I just laid out come true, it means that in future, you just need more vaccines, right? For the boosting and for the re-immunization. So I think it is time to put our heads together and look at regionalizing our efforts for vaccine manufacturing on the continent of Africa so that it can contribute to overall health security and safety.
So in that spirit, I'd like to come to each of the panelists for an answer to this question. As we are learning lessons, both from the pandemic and the response to the pandemic overall, from an economic standpoint, as Dr. John pointed out, but also from this vaccine distribution, what lessons for international cooperation can be drawn from the efforts for broader collaboration? Because the challenge of viruses is one that is not a one-off problem. We will continue to witness this level of international health challenges that will require cooperation. What lessons have we learned? Have we learned any lessons? And if so, what are those lessons? And how do we ensure that we not only build back better from an economic standpoint, but from a health standpoint as well? Let's start with you, Seth.
So thanks for that question. And you know, I'd start off and say it is evolutionarily certain we will have further outbreaks. We know that. And so, you know, if we're not prepared for them, and we are better prepared now than we were in 2009, and in 2009 better than we were from the previous one, but we need to really step up. And the most important thing we can do is to be prepared in peacetime, because what tends to happen is every time we have a new outbreak, everybody gets inspired. And then in the time between that outbreak, we saw this in 2015 with Ebola, where everybody was saying, we'll do the things we need. But then a lot of those efforts slowed down. So what are the things we need to do? So first of all, we have to have surge capacity. We have to be able to move when we have to quickly. We need contingent financing at the beginning so that one can go ahead and do what's necessary to either purchase products or to provide supplies or to work with them. And the most important thing is really building sustainable health systems because at the end of the day, it's that health system that allows you to get a warning if there is an outbreak occurring, but also is able to respond. And as John has just emphasized so eloquently, we need to make sure we have adequate capacity to make the products. Here we're talking about vaccines, but it's going to be true with drugs. It's going to be true with diagnostics. It's going to be true with PPE as well. And so, I think the challenge, and this is why the challenge that John just talked about is so important, is we have to create that capacity. It has to work for Africa, but it also should work for the world. We buy vaccines now from Africa for yellow fever. It happens to be a specialized vaccine, but for use across the world. And, we need to have that mindset so those facilities are always used and ready to go.
So over to you, Henrietta. As Seth has so eloquently stated, there's an evolutionary certainty that we will have future outbreaks. What lessons have we learned, and how can we deploy better in the future?
So one of the things we've learned, because we deal with children and young people, is that there are some tangential needs that we have not paid any attention to. So one is remote or distance education. We have had 1.6 billion children out of school. They're now 168 million. So in the next time that we have an epidemic or a pandemic, we are going to need to have the ability to connect every school and learner in the world to education. The second thing we've learned is that we are very scarce of water resources. We have so many health facilities, whether they are in sub-Saharan Africa or in the Middle East or in Asia or in North America or Europe, that do not have running water and a bar of soap. And good hygiene at a school or at a hospital makes a big difference. So water and hygiene is very important. But the two biggest lessons that I think we are all learning is we should have invested more in public health systems, primary health care, community clinics. It's extremely important for populations all over the world. John and Seth are both doctors. They know this, and we watch it every day. But if we could invest as a world in primary health care, it would make a big difference. And then the second thing that we have learned is that our people need to hear from us. They need to trust and have confidence in vaccines. There's a lot of misinformation out, whether it's online or in communities, but we have got to get on top of this so that they understand that vaccines will help protect them. And then finally, to John's point, donations are needed now. It's a race, so we've got to try to help every part of the world as soon as possible. There is a light at the end of the tunnel, but it needs to shine on everyone.
So John, finally over to you. We know we're not out of the woods yet with this pandemic, but in the responses that we've heard here today recognize what is necessary. And you reminded us that there is manufacturing capacity on the continent today that we need to scale up for the future. What are the other activities that you see as essential to ensuring that we continue to build the systems that are necessary to address the challenges now and in the future?
I think we've learned that in this pandemic, if there's, I'll be on soon. I mean, we've learned from this pandemic that we as humanity are more connected than we thought, that we as humanity are more vulnerable than we thought, whether you live in the global north or global south, and that as humanity, the inequities that exist amongst us is more than we thought. And we should be very mindful that we don't want the vaccine scenario to further widen the gap of inequity amongst our societies, whether it's within countries, between countries, or between regions. I remain hopeful that the power of the humanity will prevail. That speaks to the ability that we have to win this war collectively, and that when the history of this pandemic is written, those who read the history should remember us that we took the right choices. And again, I remain very hopeful that those who are sitting on excess doses of vaccines in the coming weeks or days should make the right choices and release those doses to COVAX so that they can distribute, so that we meet our target, or release those to regional facilities like AVAX so that we can meet our doses. I remain extremely optimistic that common wisdom will prevail.
That common wisdom, that global common wisdom, as you so wisely state, will support all of our hope that we can continue to believe in that the power of humanity will prevail. And with those words, I want to thank each of you for joining us for this very important conversation. Seth, John, Henrietta, the work you are doing out there is a blessing to the entire global community. And we're proud here at the Chicago Council on Global Affairs that you joined us for this discussion. Thank you.
Thank you.
Thank you, Ertharin.
Bye-bye.
Bye-bye.